Borelli Award presentation. My name is Paul DeVita, and just before we start, I have one announcement that if you can, would you please view the ASB opening remarks that are posted on the landing page of Crowd Compass. You will see there are 3 recorded videos by Yang He, by Elena, and I forget the third, but there are 3 of them there.
Nick Sturgio.
Okay. Nick Sturgio, president of the society. Thank you, Yang He. Okay. It is my pleasure and honor to introduce Dr. Steve Messier as the ASB 2020 Borelli Award recipient. The Borelli Award is our society's highest honor, and without doubt, Dr. Messier ranks among our most honorable members. Steve is one of the world's leading researchers in osteoarthritis, is highly respected in numerous science societies, and within the ASB is the leading researcher in NIH-funded randomized clinical trials. Not only that, Steve is the PI and the leader of a group of OA researchers who individually rank among the highest levels in their respective fields. I have worked with Steve and his group for over 20 years, and I am in awe of these people and their accomplishments. And yet, despite all their vast success, it is clear they have come together and produced a meaningful body of work in knee OA science due to Steve's leadership, his drive, and his vision. Steve Messier is a scientific leader among science leaders. Not surprisingly, Steve has many first-rate publications, and there are many citations to his work. But other researchers have more publications and more citations. Steve has an outstanding record of external funding, outstanding. But there are others with more funding dollars. Steve is not the Borelli Award recipient because of his quantitative success, which is, of course, fantastic. Steve is the Borelli Award recipient because of his qualitative success, the meaning and importance of his work, the beneficial outcomes of his work on society, and most importantly, his singular reason for doing biomechanics science to help people. Steve's love of biomechanics science is centered on his desire to improve people's lives. Many of us, including me, do science because we love to do science. It is intriguing, it is difficult, and it is fun. And we make a contribution to society through our science. This is not what drives Steve. Steve is driven to help people, and he knows that through science and biomechanics, he can. And I tell you, he has. My advice, be like Steve. Do science not because science is worthy, but because people are worthy. National Biomechanics Day likes to say, biomechanics helps people. But even more accurate would be, Steve helps people. Steve's work has reduced pain and improved physical capacity and the everyday quality of countless people's lives. That is Borelli worthy. You might ask, how do we really know Steve's work has helped people? Well, one of his publications showed that for every pound of weight one loses 4 pounds of force on the knee. One day, Steve, being a passionate baseball and Red Sox fan, left this message on my phone. I hope you can hear this.
Hey, Paul, it's Steve. I'm driving to Chapel Hill for a meeting, listening to the Major League Baseball channel on Sirius XM, with the guy saying, I need to lose some weight. You know, for every pound I lose, I get 4 pounds of stress off my knee. We are famous, Paul. We are famous. We are on the friggin' Major League Baseball channel. So I got to...
I don't know. Maybe that's his secret goal, to become famous helping baseball players. But, you know, they're people too. No matter how you look at it, Steve is always helping people. And FYI, I'm pretty sure Steve regards this MLB Sirius radio station citation as his greatest accomplishment, helping people play baseball. Steve Messier is the most generous, honest, and loyal person I know in biomechanics. Steve is also the most worthy recipient of the Borelli Award I know in biomechanics. I present to you Steve Messier, the ASB 2020 Borelli Award recipient. Congratulations, Steve. We are now ready for Steve's presentation.
Paul, can everyone hear me now?
Yes.
Okay, great. Well, thank you, Paul, for that kind and very generous introduction. The check will be in the mail. But in addition, I would like to thank the American Society of Biomechanics and the selection committee for this one of the great honors of my career. I am truly humbled by this award. So thank you very much. It's not forwarding. I have to stop sharing and share again, I guess. Let's see. There we go. Of course, there are many people that I should recognize that have played important roles in my career. And I would like to start with osteoarthritis research team, who are not only great scientists and clinicians, but people of great character. It is truly a privilege, and it's been a whole lot of fun to be a little part of this really incredible research team, as Paul had noted. Clinical trials research requires, of course, competence, but also great interpersonal skills and working with the participants in the trials. And I've been extremely fortunate over the years to have bright, energetic young men and women be part of our research team. Of special note are these three individuals who have worked with me for up to 20 years. Right? I think everyone, all the investigators on our team would agree that they are the foundation of our team. And I would hate to think where I would be without them. Also of special note are these 6 individuals who worked in my lab during the early years when we were first getting our feet wet with clinical trials research. They've all gone on to get the PhD and have had outstanding careers. In the mid-1970s, when I was a graduate student in Philadelphia, I read an article by Rob Shapiro on the DOT method for a 3D motion analysis. So after reading the article, I had a few questions for Rob. So I picked up my cell phone and I was going to call Rob. Oh, wait a minute. There was no cell phones back then. In fact, there was no internet back then, right? And so I got on just a regular landline and I called Rob. And surprisingly, he was incredibly gracious and willing to help all he could, right? Well, the result of that random call was a 45-year friendship with Rob, all because he showed a little act of kindness to an unknown, no-name graduate student from another university. Now, there is a backstory to this, and that is, as Paul had suggested, I grew up near Boston and am an avid Red Sox fan. Well, for those of you who know Rob, he grew up in New York and was all things New York Yankees. And if you don't know anything about baseball, those two things don't mix. They never have, and they never will. But somehow we overcame that. And Rob, if you're listening, I want to thank you, my friend. The most influential person in my career relative to biomechanics is Paul DeVita. As Paul said, we have collaborated for over 20 years, and he continues to challenge me on all things biomechanics. Paul is a great friend and colleague, and most importantly, he is a wonderful human being. My first NIH grant was on overuse injuries in running. And the last of 300 runners who came into the clinic to be tested was a young rheumatology fellow named Richard Loeser. Well, after he finished his testing, he came over to me and he said, "Did you ever think about doing this type of research with older adults with osteoarthritis?" Well, that simple question changed my life. Rich is now widely considered the leading international expert on cartilage cell signaling. And even 30 years later, he plays a vital role on all of my clinical trials. Other researchers, some of them are Borelli Award winners, who have in one way or another influenced my work over the years, include Peter Cavanaugh, who in 1987 gave the seminal Wolf lecture at ACSM and showed how biomechanics can help other disciplines to solve health-related problems. I'll be with you in a second. Ken Kaufman, who early on showed that gait characteristics in healthy adults differ from those in knee OA patients. I got to know Ken much better when he became a member of my data safety and monitoring board on several of my clinical trials. And I don't know if there's anyone who's more well-respected in the field of biomechanics than Ken Kaufman. Tom Andriacchi, who showed that the external knee adduction moment is a biomechanical marker for knee OA, and that varus malalignment increases the external knee adduction moment such that it increases the stress on the medial compartment of the knee, the most common location for knee osteoarthritis. Eric Radin, who showed in animal models that high rates of loading cause osteoarthritic changes in the joint. And he concluded that joints have a low coefficient of friction, and it's almost impossible that they wear down from back and forth motion, and that abnormal mechanical loading contributes to the onset of knee osteoarthritis. David Felsen from Boston University, who in 1988 wrote, "Obesity, or as yet unknown factors associated with obesity, cause knee osteoarthritis." And of course, Gait, who among his many discoveries showed how cartilage responds to loads as a result of obesity. One of his seminal papers showed that there are two pathways to knee osteoarthritis. One is mechanical and the other is inflammatory. So the possible biomechanical risk factors for knee osteoarthritis all have to do with abnormal mechanical loading. It could be in the form of overweight or obesity, as Felsen and Gait note. It could be high rates of loading, as Radin has showed in animal models, or it could be malalignment, as Andriacchi has determined. The fact is, these 5 giants in the osteoarthritis research world have set a very high standard of excellence for the rest of us to try to follow. In 1989, I met Dr. Walter Eniger, who was the head of our aging center at our medical school. Walt introduced me to clinical trials research and taught me most of what I know about that. In fact, to be honest with you, he probably gave me more responsibility in the beginning when I was struggling to learn a new discipline than I really deserved. Walt is a brilliant man, and among his many high-profile jobs he's had over the years is the president of the University of Massachusetts Health Science Center. Well, for the last year and a half, under very unfortunate circumstances, Dr. Anthony Fauci has introduced Americans to randomized clinical trials research. So the question I have is it important for biomechanists to be involved in randomized clinical trials? Well, according to the hierarchy of evidence for the evaluation of healthcare outcomes, the best way of seeking the truth are randomized clinical trials. They are considered the gold standard because they deliver the highest level of evidence due to their potential to limit bias. Randomized clinical trials provide a very high level of evidence for clinical practice. They provide information to determine the most efficacious treatments that clinicians can offer to patients. Determining the value of any new treatment in medicine requires adequately powered and well-conducted randomized clinical trials. And randomized clinical trials play a vital role in establishing standards of care for patients. So, how do we treat knee osteoarthritis? Well, the short answer is not very well. The average time spent living with symptomatic knee osteoarthritis and its surgical aftermath is over 26 years. The first 3 years are a regular cocktail of NSAIDs and braces. Then there's a period of 2 to 3 years of injections. Usually you start with steroids and then follow that with hyaluronic acid. Then there's this remarkable period of 12 to 13 years where there's no real definite treatment plan, just using analgesics as necessary. Unfortunately, half these people are just biding their time until they get a knee replacement. Our first randomized clinical trial was the Fitness, Arthritis, and Seniors trial, or FAST. It was a collaboration between Wake Forest and the University of Tennessee Medical School. Members of my department that were part of the research team were Jack Rajeski, who was a psychologist, and Michael Berry, who was a physiologist. And FAST compared the effects of aerobic walking and weight training to a health education control group over 18 months. And we found that both exercise groups decreased pain compared to the control group over 18 months. In fact, exercise has a larger effect size for pain reduction than either acetaminophen or NSAIDs. Also, the aerobic walking group increased their walking velocity compared to the control group, with the weight training group in between. So why is walking speed important? Well, for every 0.1 meter per second increase in walk speed at the age of 65 years, it is associated with an increase in life expectancy of 2.5 years. Try to remember that. That'll come back at the end of the lecture. This increase in walk speed in the aerobic walking group was due mostly to an increase in knee angular velocity. So then, FAST showed that both aerobic walking and weight training slow the decline in disability that is common in people with knee osteoarthritis and set exercise as a standard of care for people with knee OA. Well, in the beginning, we talked about how obesity is a major and modifiable risk factor for knee osteoarthritis. For example, women with severe obesity have a 17-fold increased risk of developing knee osteoarthritis compared to women of normal weight. So the question is, how do we get people who look and walk like that to look and walk like this? The Arthritis Diet and Activity Promotion Trial, or ADAPT, compared compared exercise and diet, both separately and in combination, to a control group in 316 older adults with overweight or obesity and knee osteoarthritis. The duration of all the interventions was 18 months, and the weight loss goal for the two diet groups was 5% of baseline body weight. And we found that the diet and exercise group lost on average 5.7% of their body weight, while the diet-only group lost 4.9% of their body. The big winner in this trial was the diet plus exercise group, who had significantly less pain and better function than the control. Also, the diet group, the exercise group, and the diet plus exercise group all decreased C-reactive protein levels, which is a marker of inflammation, compared to the control group, which actually increased inflammation. When we divided these four groups by weight loss, the high weight loss group lost an average of a little over 17 pounds, while the low weight loss group actually increased weight by about 1.2 pounds. This resulted in a difference in knee compressive forces during walking of about 80 pounds between the two groups. Hence, for every 1 pound in weight loss, there was about a 4 decrease in knee compressive forces per step. But you already know that because Paul stole my thunder on that way before. Also, we looked at survivorship of the ADAPT cohort 8 years after they completed the study, and found that those that were randomized to the weight loss groups had 50% less mortality than those randomized to the non-weight loss groups. So then, we recommend that physicians use diet plus exercise as an integral part of their treatment program for older adults with overweight or obesity and knee osteoarthritis. So then we asked ourselves, is more better? Can we achieve even greater long-term weight loss, 2 to 3 times what we achieved in ADAPT? And would this improve clinical and biomechanical outcomes? The Intensive Diet and Exercise for Arthritis trial, or IDEA, compared 3 intervention groups: an exercise-only comparison group, a diet-only group, and a diet plus exercise group. The diet goal for the 2 diet groups was at least a 10% weight loss over a period of 18 months. The diet-only group lost an average of 9.5% of their body weight. The diet plus exercise group lost 11.4% of their body weight. And the exercise-only group lost 2.2% of their body weight. All 3 groups reduced pain by about the same amount after 6 months. But by 18 months, the diet plus exercise group had separated itself from the other 2 groups with an almost 50% decrease in pain, compared to 26% for the diet-only group and 32% for the exercise-only group. So all 3 groups did well. The diet plus exercise group is significantly better. Also, 38% of the diet plus exercise group recorded no pain at 18-month follow-up, with scores of 0 or 1 on a scale from 0 to 20. So then, the same pattern of pain reduction was apparent in both ADAPT and ICA for the diet plus exercise group, shown here in the black line, with twice the weight loss in ICA having twice the effect on pain. We use the DaVita 3D musculoskeletal model to determine gastrocnemius, hamstring, and quadricep muscle forces that we use to determine knee joint compressive and shear forces. And found that the diet-only group had significantly lower peak knee compressive forces compared to the exercise-only group, with the diet plus exercise group being in between. Here you can see nicely in the shaded area that the peak hamstring and quadricep forces contribute greatly to that first peak knee compressive force. And the significant decrease in the diet-only group in knee compressive forces was due in large part to a significant decrease in the hamstring force compared to the exercise-only group. Hence, the diet group had less co-contraction at the knee. The same pattern was apparent for the quadricep forces, although there was not a significant difference, with the diet groups tending to have lower values than the exercise-only group. The peak gastrocnemius force contributed greatly to the second peak knee compressive force, shown there again in the shaded area. The gastrocnemius and soleus, the plantar flexors, control forward motion of the body, stabilize upper body mass, and assist in propulsion. Both diet groups, the diet and the diet plus exercise group, had significantly lower gastrocnemius muscle forces compared to the exercise-only group, suggesting then that less muscle force is required to control a lighter upper body weight. We also measured knee compressive impulse, a measure of the total compressive load on the knee per step, and found that both the diet and the diet plus exercise group had significantly lower knee compressive impulse values compared to the exercise-only control group. IL-6 was our measure of inflammation, and once again, we saw that the two diet groups had significantly lower inflammation values at 18-month follow-up compared to the exercise-only group, which tended to actually increase inflammation, just like they did in ADAPT. So therefore, intensive weight loss with and without exercise reduces abnormal stress by decreasing knee joint loads, and reduces abnormal physiology by lowering inflammation, resulting in what is important to the patient is less pain and less disability. What's important to third-party payers is the intervention cost-effective? Well, a quality-adjusted life year is 1 year of perfect health. An ICER is an incremental cost-effectiveness ratio, which is the difference in cost or the willingness to pay divided by the difference in quality-adjusted life years gained. A willingness to pay threshold of $100,000 for quality-adjusted life year gain is considered cost-effective. A willingness to pay threshold of $50,000 for quality-adjusted life year gain is considered highly cost-effective. The ICER for the diet and exercise group in IDEA was $34,000 for quality-adjusted life year gain. Hence, diet and exercise is highly cost-effective. Now, not everyone in the diet groups in IDEA reached their weight loss goal of 10% of body weight. In the diet and exercise group, for example, and the same was true for the diet-only group, 50% of them achieved greater than 10% weight loss. 25% were between 5 and 10%, and 25% were less than 5%. We all know that as we age, muscle mass decreases and fat mass increases, right? For example, the average person in IDEA had a thigh that was 61% fat. This excess of fat can act as a wobbling mass and may increase the torques at the knee during walking. So then we thought, is it possible with high intensity strength training to increase thigh muscle mass, decrease thigh fat mass, and get a similar reduction in pain and knee joint loads as with weight loss? There are some indications that this may be true. Paul DeVito has shown that 12 weeks of strength training in knee OA patients significantly decreased pain compared to a control group. So the strength training for arthritis trial will start, randomized 377 participants to one of three groups: high intensity strength training, low intensity strength training, or a healthy living control group. All three interventions were 18 months in duration. Knee extensor strength and knee flexor strength were significantly greater in both strength training groups compared to the control group. So the intervention did what it was intended to do. It increased strength in older adults with knee OA compared to control. However, this increase in strength had no effect on pain reduction compared to a control group, with all three groups decreasing pain by about 33%. Also, we found that increasing muscle strength did not reduce knee joint, with increases between 6 and 10% among the three groups after 18 months of the intervention. The increase in strength had no effect on thigh muscle volume or on thigh fat volume. However, there was no indication that disease progressed faster in the high intensity, and the changes were consistent with natural history progression. So the high intensity strength training really did not do any harm as far as the knee goes. The percent of patients using pain medication declined across all groups after 18 months. So then, is high intensity strength training beneficial or harmful for older adults with knee osteoarthritis? Well, it is safe. Older adults with knee pain are willing to do it, and for a long term. It does not exacerbate disease progression or pain medication use. It increases strength, but has no effect on knee joints, and is no better than attention control in reducing pain. So, exercise versus weight loss. Which is better for people with knee OA? Well, taken together, our data would suggest the greatest benefit for patients biomechanically is weight loss. However, clinically, it is weight loss when combined with exercise. Now, a common response of physicians to our work is that, Steve, these data are great, but we have no practical means to implement weight loss and exercise treatments for our patients. So we set out to see if we could get the same results as we have in IDEA in a community-based study. It's the weight loss and exercise for communities with arthritis in North Carolina, or the WECAN trial. The WECAN is a phase 3 pragmatic, assessor-blinded, randomized clinical trial of 823 participants from 3 counties in North Carolina with diverse residential and socioeconomic composition. We are about 1 month away from having the results of that study. However, we do have some baseline data that I think are interesting to look at. We took the 823 participants and we grouped them according to obesity class. Class 1 obesity is BMI between 30 and 34.9, and there were 389 people in that group. Class 2 obesity is between 35 and 39.9, and there were 230 people in that group. And class 3 obesity is a BMI of greater than 40, and there were 204 people in that group. If you look at that first row, the first line, as obesity class increased, walking velocity decreased by about 0.1 meters per second per class. Now, if you remember at the beginning of the talk, right, we asked, is walk speed important? And yes, for every 0.1 meter per second increase in walk speed, there's an increase in life expectancy of 2.5 years. So that decrease in walk speed of 0.1 meters per second per obesity class, as obesity class increased, is clinically important. We go back, of course, the decrease in walking velocity as obesity class increases resulted in a decrease in stride length and swing time and an increase in stance time. Also, as obesity class increased, there was more of a need to feel more stable. And so the base of support, or the distance between the 2 feet, increased, and also forefoot abduction increased, all in an attempt to be more stable as they became more obese. So for the last 30 years, we have focused on reducing pain in adults with knee osteoarthritis with exercise and diet. However, there is no cure for osteoarthritis. So the question is prevention better than treatment? Can weight loss and exercise prevent the onset of knee osteoarthritis in people at risk for the disease by modifying the biomechanical and inflammatory disease pathways? We are at the end of the first year of a 2-year planning grant that will try to determine whether we can actually prevent the onset of knee osteoarthritis with the Osteoarthritis Prevention Study, or TOPS. So in closing, first, I would like to thank you all for taking time out of your busy day to be here this afternoon. And finally, I would like to recognize my family, 4 children, 4 spouses, 7 grandchildren, as a way of grounding and making you realize what's really important in life. And it is all orchestrated by the love of my wife, Vicky. Thank you very much. It's been an honor being here.
Thank you very much, Steve. Let's everyone applaud. Your presentation showed 2 fabulous aspects of your work: the immense successful clinical trials that you run and the important results and content that you produce. Extremely valuable. Thank you so much for your work. We have questions in the chat room, and some of them, as I suggested to the audience, might pertain to actual clinical trials, and everyone recognizes so strongly your ability to conduct such great clinical trials. So there are a few questions about sort of procedures. The first is from Steph DeStassi, and she asks or says that she's interested to hear some of your advice on how to run such long-term intensive trials with repeat biomechanics assessments. How do you manage these long-term trials?
Well, I mean, it's all about your staff. Right? The first thing is that you have to be able to recruit people. And so recruitment in a clinical trial is the lifeblood of the trial. And very interestingly, 80% of the clinical trials that are funded by the National Institutes of Health do not reach their recruitment goals. Well, as you write a proposal, you have what we call power calculations, and it's based on achieving a certain recruitment level. So if you don't achieve that recruitment level, then your power for your study goes out the window. So we take a lot of pride and we have never not achieved our recruitment goals, no matter what size the study is. We put a lot of effort into it, which means you put a lot of money into it too. But that's got to be the first thing. And it's not just recruitment of one person, the recruitment, the coordinator, of course, that is important, but everyone participates in that. And one of the things, so then once you get the people in the study, then you have to retain them.
Right.
All right. And so one of the people in our research group is a health psychologist, Dr. Shannon Mahalko. And she trains not only our interventionists who work with the participants, but the people who test them as well in social cognitive theory and how to deal with patients. Also, we have 25 undergraduate students that help each year in our clinical trial. That's great, free help, believe me. But I tell them that, it's equally important. The minute they walk in and if they are dealing with a participant, they can either have a good impression on them or a bad impression. And a couple of bad impressions get out in the community, and then your name in the community is not what you want it to be. And so we have always really prided ourselves on making sure that we are on the minute you walk in and you're working with a participant. They can do no wrong. You never get down on a participant. We've had participants come into a study. They've been gone for 6 months, and they walk in and they've been afraid to walk in because they think they're going to get scolded, and they're greeted like it was the first day, and they can't believe it. And that's how you win over people. And so it's the psychology of it is really important. When I first started doing the clinical trials and they talked about having a psychologist, I went, I'm a former engineer, right? I mean, that's soft science. And I'm thinking, that's not good. Well, I hate to say it, but I don't go anywhere without my psychologist now. So it's how you treat the people, and it's the effort you put in to recruit them and to retain them that's really important. The other reason for 18-month trials is I believe you can do anything for 6 months. And the 18 months is more like real life. All right, so the results you get in a very short-term study are nice, but they're really not practical.
Thank you, Steve.
I don't know if that helps her at all, but
I will also add to that your comment about the psychology. Our psychologist in this group is Shannon Mahalko, as Steve mentioned, and more or less her ideas are verified more often than everyone else's ideas. It is the psychological effects and impacts that occur on these people and with these people that determine much of the outcome. So I congratulate her and point that out. The other side of the coin now is addressed by Allison Gruber. What recommendations do you have for an individual researcher with a smaller group, a support staff of 3 PhD students for conducting a successful RCT?
Well, Allison, Ron, hi. Nice to see you, so to speak. Well, we don't even have a PhD program at Wake Forest, as you don't either, Paul. And so I have one master's student each year. And we're a small program. And as I said in the very beginning, it's important to have a good staff. And you start with your project manager. My project manager has been with me for just about 20 years. And that person is so important to you. And then when you bring on other staff, she can convey the level of detail and the level of expertise that you require in order to be part of the group. And that just permeates throughout the whole group. So then at the end, I don't ever have to say anything because it's expected. There's a certain standard of excellence that's expected. And if you can't meet that standard of excellence, then it's okay. There's nothing wrong. This just isn't the place for you. And so I think the staff is really important. And it allows the researcher, even in a small environment, to be able to write the grants and do the big thinking because you're so confident that the execution of the study is going on even better than what you could do yourself.
Thank you, Steve. And we have several content-based questions, but there is one more additional procedural question from Srikant Vallabhajasula. And he asks, as an add-on to Allison's question, what mechanisms can individual investigators pursue to obtain external funding to set up such support systems?
Well, I mean, you start out small. If you have an idea, well, the most important thing about research, and this has nothing to do with biomechanics, it's amazing being on study sections at NIAMS, the lack of good questions. I mean, you have to have a good question first. And if you have a great question, then you figure out how you're going to try to answer that question, as opposed to the other way around, where you have all these great toys, and we've got great toys in biomechanics, and say, okay, what can I do with these great toys? That's not it at all. It should be the other way around. Have a great question, and then figure out how you're going to answer that question. And NIH has a number of mechanisms for that. The first is an R21, which is a very small grant, and they don't expect you to reach statistical significance. And if you're planning to do a larger trial, you do that first, right? And kind of get your feet wet, get everything ready. And then you can go on from the R21 to an R01, right? Which is then the clinical trial. It is amazing how few clinical trials there really are that come through, at least the group that I'm with in NIAMS. So I mean, it's not everyone has to do clinical trials, but I really think that for PhD programs, especially if the biomechanics program tends to be health oriented, I think there should be 1 or 2 classes in public health where people learn about randomized clinical trials, in case when they get to be an independent investigator, that's something that they want to do.
That's interesting, the comment about the R21s. Those are also considered to be sort of, as I say it, investigating new and maybe wild ideas. So as Steve is saying, it's the idea that is the most important aspect or element of our proposals. And this mechanism is a smaller proposal that really focuses in on the idea, the hypothesis, and how intriguing it might be.
Right. If you're at a small university, right, at a tiny place that there's not a lot of research being done, and you get there and you say, okay, I want to start a biomechanics program here. There is another mechanism that's called the R15,
right,
which is called the area grant. And that was my first one. That was my first grant. That was the one that I had. I brought in 300 runners on. I think the grant was $100,000 over 3 years. And so the R15 is another way to go, and that's particularly designed for small university settings in which they're not real research one institutions.
And they have a strong educational component to them also.
Yes.
Dustin Crouch asks on the content of your work, does it matter what exercise patients do? Does it have to involve the lower extremities for at least some part of it? In other words, what's making the difference? Exercise mechanics or other exercise benefits?
That is a brief question that requires about 2 or 3 days to talk about. The more work we do with exercise, and as you may have noticed in the strength training study that the control group did, as well as the 2 strength training groups did. So the question becomes, in this population, what part of exercise, what part of the effect of exercise is really just paying attention to people? I really start to wonder that, and maybe there's regression to the mean as well, but is just paying, if I can just pay attention to people in that control group in that START trial, right, met 24 times over 18 months for 1 hour and got the same effect on pain and function as 18 months of strength training. It really makes you wonder in this population, now I'm talking just about older people with osteoarthritis, how much of the effect of exercise is really just paying attention to people.
So that is the psychological component, as you're saying. I think it's interesting that so many different exercise programs have had success in reducing pain and disability in this population. So one might think, what is the common feature that different exercises have? And advance or investigate that question or approach the question from that direction.
Right.
Christia Nelson asks, with the CT scans of the thigh muscles after intervention, were there any measures of fat infiltration changes versus just muscle volume?
Well, there was muscle volume and there was fat volume. We showed muscle volume and we showed fat volume. The majority of fat is underneath the skin, right? Subdermal, right? And that's where the majority of fat is. I think in the 98% of the fat. And then there's a small amount that is between the muscles, intermuscular fat or intramuscular fat. And we did measure those, but for what we were looking at here, the overwhelming amount of fat is that fat that's just below the skin, and that really overwhelms what's between the muscles. And so we have those data, but we haven't actually looked at done a study with that.
Thank you. We have a question from Maddie Major. First, wonderful talk. Congratulations. Due to these exercise and/or diet interventions, have you observed any changes in inflammatory markers, e.g. IL-6, that contribute to successful outcomes?
Absolutely. I think we showed that. We showed a decrease in C-reactive protein, a decrease in IL-6. And so what was really interesting, and I think I showed a slide at the beginning from Foch, and how in one of his seminal studies actually showed two pathways, a mechanical pathway, which is really load, right? And an inflammatory pathway, which has to do with the cytokines that are in the fat and produce kind of a cartilage degradation effect. And what we've seen is that Foch was right on target, that there are two pathways to OA. One is mechanical and one is inflammatory. We have added a third, which is psychological, which is self-efficacy. And it's not a direct pathway, but it is a mediator of those other two. And so we've added a third one, which is the psychological component that, Paul, you've been talking about.
Thank you. And I think we could all agree that if anyone is right on target in biomechanics, it is Foch Gilak.
I would think so.
Okay. Ajit Chaudhary asks, can you talk a little bit about the planning grants that you use them like in TOPS, or excuse me, and how you use them like in TOPS?
Sure. For one thing is that they're very difficult to, it's very difficult to figure out what they want in them. The ones I reviewed, for example, there's the planning aspect of it, but then there's where are you going to go with this? And so it's very difficult as someone who's running that grant to know how much to talk about the big grant that you want to do, as opposed to the planning that you're doing to get the big grant. And it's very difficult to figure out that. And so I've been on enough study sections and done enough of them myself that I think, we kind of figured it out. But you have to do both. You have to show that you're going to plan, but then you've got to already kind of have the the grant that you want to do, the trial that you have to have that all figured out already. Because the reviewers are going to score that as much as they're going to score the planning aspect of it. Now, what kinds of neat things that we do with the one that we have? First of all, the planning grant that we have now, I didn't want to do it. I said, we're ready to go. Let's just do the big grant. It's a 5-site international study with 1,700 people. I said, we're ready to go. And I got talked out of it by the other investigators. And I'm so glad I was talked out of it. Because one of the things we've done is mock recruitment. You cannot do recruitment, all right? But you can do a mock recruitment to show that it's possible for you to recruit the people you say you're going to recruit. All right, so we've done that at the 5 sites around, well, there's 4 sites in the United States and 1 site in Australia. And so that's been a big thing. The other thing is you can really get a head start on your manual of operations or your MOP. I think that's really good. The other thing is if you have more than 1 site, then you have a chance to go to those other sites and make sure everything is the way that you want. So everything is coordinated, which has been impossible with COVID. So we have more Zoom meetings than I would like to think about. But so I think a planning grant is, if you have a multi-center trial, right? I think a planning grant is a good idea. Just understand that that has to go through the review process, just like the R01 or the U01 will. So it's going to put you 2 years behind, as if you just went for the R01, and if you got it funded right away, then you're 2 years ahead of where you would have been. But with big grants, with multi-center trials, I've become an advocate of it, even though in the beginning I wasn't so much. But they're difficult to, it's difficult to figure out what to put in them. Having said that, and trying to stay with what I said about Rob Shapiro in the beginning, you know, I'm an old guy. I've been around a while. This is all about the young folks. I'd be happy to look at anything anyone wants, as long as I'm not part of a study section that you're going to submit to. But I'd be happy to provide what little input that I could for anybody. It doesn't matter. I don't even have to know you. I don't care.
Thank you, Steve. And Ajit, I will say one more thing. And for the group, one of Steve's great skills also is communicating with the people at NIH, especially the program managers. So he is saying how it's a difficult decision or process to create these planning grants and to know what is needed to be included, but communicating with the personnel at NIH will certainly help with that. Right. We're almost out of time, but I would like to ask one more question, or have one more question from Jason Franz. And he says, thanks for the wonderful talk. Habitual gait speed associates with survival among persons 65 plus years. However, how confident are we in the prospective benefit of interventions that increase walking speed on the same associations? There's a lot to be said about the phenotypes of people that happen to walk faster at baseline in that seminal work.
Yeah, just the key word there was association. Stephanie Studinsky did that trial, did that study, and it was published in JAMA, but it's an association, right? But what we've seen is our folks, after they get through with diet and exercise, for example, their walk speeds have increased, where somebody who is 65 years old, what you see is a decline in walk speed over time. So our participants are going in the exact opposite direction that the normal population at that same age is going. So I really think the interventions are doing their job. Whether that increases their longevity, I don't know. I mean, we looked at the ADAPT study, right? 8 years later, and it was 50% less mortality, but that had to do with the diet group, right? It was the diet and the diet plus exercise group. So we don't know for sure to answer that question, but it certainly looks like diet and exercise in this population has a positive effect on longevity.
Thank you very much, Steve. It is time to stop this session. However, please keep in mind that there's now a discussion with Steve in the Borelli room and spatial chat. So any questions that you have, we can continue discussing in that room. So please attend that room. And thank you very much for attending the session. And once more, congratulations, Steve and Messier, 2020 ASB Borelli Award recipient.
Thank you, Paul. Thank you.
You're welcome. Thank you. Thank you, everyone. We can leave now.
Okay, how do I get into that room?
You have to go to, okay, I'll stay on with you. Everyone exit. So do you know the crowd compass?